Welcome to Viremic, Cases in HIV, hosted by Dr. Eileen Scully and Dr. Christopher Hoffmann, both HIV specialists at Johns Hopkins, who explore quandaries in adult HIV care. Each case discussion includes medical history and diagnoses, challenges in care and treatment, and key evidence and guidelines that inform clinical decision-making. Cases are presented as a composite from the host's clinical practice, with all identifying details removed to protect the privacy of patients. Case discussions are for informational purposes only and not offered as medical or clinical practice advice for patients or clinicians. Any mention of specific medications or commercially available products is a description of use only, not an endorsement.
Welcome to Viremic. I'm Chris Hoffmann, and I'm joined today by longtime mentor of mine, Dr. Joel Gallant. I first became aware of Joel even before I started residency at Johns Hopkins, and his presence there was one of the reasons that I chose to go to Hopkins for internal medicine residency and stayed on for infectious diseases fellowship. It's wonderful to have Joel today to discuss AIDS 2026 key findings in clinical medicine. Joel, welcome to the podcast.
Thank you so much, Chris. Thanks for the kind introduction, and it's a pleasure to be here to talk to you about the latest International AIDS Conference.
Before we start, if you like this podcast, please share with a colleague and follow us wherever you access podcasts. In addition, we love hearing from listeners, so please send questions or future topic suggestions to us at viremicpodcast@jh.edu. So again, welcome, Joel. Look forward to discussing clinical insights from the AIDS 2026 conference. But before we begin with that, can you share with the listeners a little bit about what led you to a career in HIV care?
Sure, it's kind of a complicated story, but I'll try to make it brief. I started medical school in San Francisco in 1981. That was ground zero for at least the West Coast epidemic of HIV. Never intended at the time to make a career out of it, probably because I had too much personal fear tied up in it based on my own risk. But throughout my training, I was taking care of lots of people with HIV. I was working in HIV clinics. And I was always interested in infectious diseases. But people told me, well, you have to do your research in a lab if you do a fellowship. I didn't want to do that. I ended up coming to Hopkins to get a degree in public health with an interest in parasitology and international health, but got recruited to work in the HIV clinic there. And Hopkins was such a dominant force in HIV back in the early 90s, due in part to the leadership of John Bartlett. And one thing led to another, and ended up making that my career.
So you started in clinical medicine at a very different time in the world of HIV, certainly. What would you tell a clinician interested in HIV care who is starting training or starting their clinical practice now?
Well, it is very different. Obviously, the treatment for HIV has become much simpler. And I think now there are legitimate questions about who should be providing the majority of HIV care because it is gratifyingly so simple. Some people argue that the specialization into HIV would go away when things got like this, but that hasn't happened. The pipeline is still robust. There's still lots of interesting research going on HIV and its treatment. So, although I think that from a clinical standpoint, things have really changed, it's still a very exciting field to be in. And the recent Rio conference was just more evidence of that. Lots of young people doing great research and presenting great papers. So I'm still optimistic, even though people may be going into it for different reasons than they were back in the 80s and 90s.
Well, with that, why don't we switch to discussing some of the exciting clinical science from the Rio AIDS 2026 conference. I'll start with asking you if there's a particular potentially practice-changing study that you could highlight.
I thought about that, and I can't come up with a single study. Let me say this. If you had asked me back in the early 90s, if we someday got to the point where we could treat people with HIV with one pill a day that was effective, safe, well-tolerated, convenient, would we still have a drug pipeline? I would have said no, we'd be done. Other than trying to find a cure and a vaccine, we would be done at that point. I was so wrong. I would have been so wrong because the pipeline is still very robust. It's now two broad categories of reasons why the pipeline is robust. One is to simplify therapy for people who are on complex oral daily regimens. And the second is to provide long acting therapy, whether oral or parenteral, for people for whom that would be helpful. At Rio, there were lots of studies presented on, especially on long acting therapy, which really show that there's still a need for further drug development, even though I think we've conquered the problem of a single tablet once daily oral therapy for most people. That isn't going to work for everybody. So it's great to see choices in our future.
Well, let's discuss some of those choices. Why don't we start with the tried and true Cabotegravir, Rilpivirine, or Cabotegravir, and 96-week results from the LATA study that was conducted among adolescents aged 12 to 19 living with HIV in Sub-Saharan Africa, and compared every 2 months injections of Cabotegravir to the standard regimen used in much of Sub-Saharan Africa, TLD or Tenofovir, Lamivudine, Dolutegravir. In this study, close to 500 participants were enrolled with a median age of 16 and nearly 12 years of prior antiretroviral therapy. In the long-acting injectable arm, there were 2 participants, or 1%, versus 15 or 6% in the TLD arm who experienced a viral load greater than 50 at 96 weeks. Of the participants in the Cabotegravir arm, 1 developed a serious hypersensitivity reaction and had to stop Cabotegravir. Otherwise, side effects were pretty minimal in both arms. Any comments or thoughts about this study, Joel?
This is a really important study of Rilpivirine, brand name Cabenuva, in African adolescents. And the results were surprising, especially when you figure that these were kids who were already suppressed. These were people who had been adherent on TLD and yet still did better with Rilpivirine, 2 versus 15 with viral rebound. And not only that, when asked which one they preferred, they were definitely preferring the injectable regimen. I think this has important implications, not just for Africa, but for everywhere. Adherence with antiretroviral therapy has been notoriously complicated with adolescents for all the reasons you would expect. And if we can come up with something that they will take, then that's great. It also, I think, raises the question of access because in many parts of the world, Rilpivirine is not available. And this study points out the need to make it available to places that need it.
In some of the clinical trials among adults in the US of Cabotegravir and also some of the cohort and observational studies, failure rates have been higher than 1%, maybe 1 to 3% after even just 1 year. And here at 96 weeks, it was only 1%. Does that suggest anything to you?
Yeah, well, 1 to 2% is a number that I toss around when I look at the clinical trials that led to the approval of Rilpivirine. There's no question that the resistance barrier is a little bit lower than it would be with once daily oral therapy, the standard of care regimens. When you fail, you can fail with an RTI resistance and you can fail with Cabotegravir resistance, which can sometimes cause cross resistance to Dolutegravir and Bictegravir. So when I talk to patients in the US about this, if they're doing great on once daily oral therapy and they want to switch because a friend of theirs is on the drug or they saw a commercial for it, I have to tell them, look, we can do that, but you need to know that you're going from essentially 0% risk of resistance to maybe a 1% risk of resistance, which is small, but not nothing. On the other hand, for people where injectable therapy could be life-saving because they've consistently shown that they're just not able to take oral therapy for whatever reason, as we've seen in some recent studies, then I think there's no question that that small risk of resistance is well worth the potential benefit of being on something that they'll take.
Well, perhaps a combination with a slightly higher barrier to resistance, although maybe yet to be seen, is the combination of Islatravir plus Lenacapavir, which was presented in 2 landmark studies, ISLAND 1 and ISLAND 2. Islatravir is already FDA approved for once-a-day use in combination with doravirine. It's a nucleoside reverse transcriptase translocation inhibitor, which is a novel mechanism. It inhibits HIV replication as both a chain terminator and a translocation inhibitor. Island-1 was a placebo-controlled trial, about 600 participants with a median age of around 50, 21% were women, 31% Black. And at week 48, Islatravir, Lenacapavir, compared to Bictegravir, FTAF, showed 0 virologic failure in the Islatravir, Lenacapavir arm and 1 in the Bic-FTAF arm with a viral load greater than 50. One of the key things was CD4 count change. In the Islatravir arm, there was a decline of about 10 versus a decline of 18 in the Bic-FTAF arm. The side effect profiles were similar in the study for both arms. The other Islatravir lenacapavir study, Island-2, looked at 620 participants with a median age of around 50. 34% were women, 31% Black. Similarly to Island-1, at week 48, there were very few failures in either arm, with 1 participant with a viral load greater than 50 in the Islatravir arm and 4 with a viral load greater than 50 in the standard of care arm. In that study, the mean change in CD4 count was a decline of 45 in the Islatravir arm and a decline of 8 in the standard of care arm. Similarly to Island-1, there were minimal side effects. For both studies, I think it's important to highlight there was 1 discontinuation in the Islatravir arm due to development of acute hepatitis B infection. Any comments on this study, Joel?
Yeah, the first I'll say is that as an investigator on this study, I've been trying to pin people down as to whether it's pronounced Island or Island, and I've heard people from Gilead and Merck say it both ways, but Island seems to be the predominant, so I'm going to say Island. These are 2 important large studies that will almost certainly lead to the approval of this weekly combination, the first weekly oral long-acting treatment. That's important because, although a lot of times when we talk about long-acting therapy, people think about long-acting injections given every few months. But not everybody wants injections, and not everybody wants to come into clinic to get injections. The standard of care now is you come in once every 6 months, but with some of the injections, you have to come in more often. So I think this is a great option for many people who like the idea of long-acting, but really are not into the injection part. So the results look great. Island-1 was a placebo-controlled trial because the comparator was BF-TAF or Biktarvy, and so it was easy to do a placebo control. And there we saw no difference in terms of treatment-related adverse events. In Island-2, where you couldn't do a placebo because people were on too many different comparator regimens, you did see more treatment-related adverse events, but that's typical of an open-label study. If somebody knows that they've been switched to an investigational product and gets a headache, they'll report it. Whereas if it's a headache on the same regimen they've been taking for years, they're less likely to report it. I think these are really important. They're going to be registrational studies. One thing, and this is going to be a recurring theme that I'll probably fail to mention with every one of these studies, but we have to think about the importance of hepatitis B immunity and whether or not people have chronic hepatitis B. Remember, there is no tenofovir component with this regimen. Therefore, if somebody has chronic hepatitis B, they can have a potentially dangerous flare. And if they are non-immune to hepatitis B, they're no longer going to be protected from infection the way they probably were with tenofovir. So make sure and check hepatitis B status and vaccinate if non-immune. And then the other thing to remember is I've heard some people confuse this with Bic-Len, which wasn't a big topic at the conference, but is going to be out there soon. That's a once daily 2-drug oral regimen. Bic-Len has been studied in people with fairly extensive resistance, as long as they didn't have resistance to Bictegravir. Whereas in the Island studies, remember that these were people with no history of virologic failure. M184V potentially affects Islatravir susceptibility. So this is not something that you use in a more of a salvage situation. This is really for people who have been doing well on their initial regimen without prior failure, without M184V, and who just want to switch to a weekly oral regimen. And we can talk more about the resistance implications later because this comes up again. But I think these are really exciting studies.
Well, maybe now is a good time to talk a little bit more about some of the M184 resistance implications with the use of Islatravir. Just as a hypothetical, if a patient who maybe struggles with daily antiretroviral therapy takes ART once or twice a week, it would seem like Islatravir or Lenacapavir could be a potential option. Well, what if they had some minimal resistance developed through their struggles with adherence, including the M184V and maybe an NRTI mutation?
Yeah, it's a great question. If you look at the Stanford resistance database, it will tell you that M184V is an islatravir mutation. Now, there was a study presented in Rio looking at people who had proviral DNA done at baseline. And they looked back to see what about people who weren't known to have 184V, but it showed up on their proviral DNA. They presented 96-week data and showed that even though prior virologic failure was exclusionary, therefore nobody really should have had 184V, 300 participants in these three trials had nucleoside resistance and 66 had M184V or I, and yet virologic suppression was over 95% despite those mutations, including 184V or I. Now, this is not a definitive study, in part because this is proviral DNA. People have questions about the assay and what it means. I think one of the big lessons in this is take a history, because here are these large number of people in the three switch studies who were said not to have ever failed before, and yet 300 of them had nucleoside resistance. So obviously, you got to be taking history. So in other words, I guess I wouldn't do this deliberately if I knew somebody had 184V. However, it gives me a lot of reassurance that we know we're going to miss 184V once in a while. And this gives reassurance that it's probably going to work anyway. And it may have to do with the drug levels being high enough. Now, I'm sure that Merck is going to be interested in pursuing this further with a more definitive study. And I hope they do, because that might give us even greater reassurance, and it might make us willing to use this even with known 184V. Again, in the situation you described, if this is someone who simply will not take once daily oral therapy, but would be a good candidate for this, I might take that small risk, because ultimately what matters is that they take something, and you're probably going to get away with it. But we need more data before we can deliberately say, oh, I'm happy using this combination with 184.
So another weekly therapy trial with Islatravir was a phase 2b trial of Islatravir combined with a novel NNRTI that is not susceptible to some of the first-generation NNRTI canonical resistance mutations. That NNRTI is Ulonivirine. And this was a switch to Ulonivirine Islatravir, or continuation of BIC-F-TAF among adults with a viral load less than 50. And again, the Ulonivirine Islatravir was once a week. Obviously, BIC-F-TAF is daily. And 157 participants were randomized. Median age was 48, 26% were women, and 32% were Black. At week 24, none of the Islatravir Ulonivirine compared to one, and the BIC-F-TAF had a viral load greater than 50. There were a number of mild drug-related AEs in the Islatravir Ulonivirine arm. Any comments about this, Joel?
Yeah, this is an earlier phase study, 2B, but it looks very promising. I'm going to pronounce it Ulonivirine until someone corrects me. It's an NNRTI that has activity against NNRTI-resistant virus, and that has a pharmacokinetics that allow it to be given weekly. Again, these are people with no history of virologic failure, and in part because of that islatravir concern that we just discussed. And of course, they could not have active hepatitis B. And they did great. Nobody met criteria for resistance testing. Now, one person stopped because of a rash that was presumably due to Ulonivirine, in combination with the LATA study that we just discussed, where there was a rash that was presumably due to the Rilpivirine component of Cabotegravir. It's something we always have to remember, that NNRTIs as a class can do this, but it doesn't seem to happen very often. So this will be moving on to phase 3 and would be another promising regimen for weekly oral therapy.
I think it just gets back to the issue of prior resistance, especially with the Islatravir. And I hope that we have some promising data at future conferences and publications suggesting that it may be compatible with M184V.
Exactly. That would simplify things a lot.
Moving from every week or every 2 months to every 6 or 12 months could be even more transformative. And I believe you were part of a study with monoclonal antibodies, tirapavimab and zinlervimab, along with subcutaneous lenacapavir, and the 104-week outcomes were presented at AIDS 2026. To summarize, this was a switch study for virologically suppressed individuals who were randomized to continue either their stable regimen or switch to every 6 months len-tab-zab injections, subcutaneous or IV, depending on the agent. At week 52, all participants were eligible to switch to len-tab-zab or continue on len-tab-zab if they were randomized to that originally. Of 53 who were randomized to the novel regimen, 47 continued, and of those on standard of care, a large number switched over also. At week 104, very promising results in terms of viral load, less than 50. And correct me if I'm wrong about this, Joel, but those individuals who received the novel regimen throughout the entire study, that means they received 4 doses of combination antiretroviral therapy during that time, compared to 730 daily tablets that people in the daily oral arm would have taken. So pretty exciting. And you were part of this, so perhaps more insight from you.
Sure. Even though I'm an author on the study, I'm very glad that you attempted the pronunciation of the antibodies so I can just say tab and zab and not have to embarrass myself because they are difficult. But yeah, this is a big phase 2 study. The previous 52-week results had been presented, and 89% who were on this therapy remained suppressed. So now we're seeing 104-week data. At the end of 52 weeks, those who were randomized to stay on their continued oral regimen were able to switch over, and most of them chose to do that. So 98% of those who were originally randomized to the len-tab-zab were suppressed, and 100% of those randomized to the oral suppressed when they switched. Of course, they were already suppressed at switch. Now, there were 2 with rebound, and with rebound came resistance to the antibodies and resistance to lenacapavir. That wasn't a problem for them because they were able to resuppress on BF-TAF. But this rebound is not due to adherence issues because they all got their on-time injections, and adherence with pills obviously is not a component of this. So that's something we can talk about. But certainly this is right now the only real candidate for twice yearly dosing. And that alone makes it very exciting, I think.
What do you see as the role for monoclonals for therapy, including this combination and perhaps other combinations?
Well, there are a lot of unanswered questions. First of all, it's important to note that you have to do susceptibility testing, not for the lenacapavir, but for the antibodies, because plenty of people have baseline intrinsic resistance to these antibodies that cannot be predicted based on anything in their history or clinical experience. So you have to do the tests. And the tests right now, they can take quite a while. Now, that's not a big deal because people are suppressed on oral therapy, so they can wait. But in this study, they started out with 241 people who were being screened. Of those 41, the assay failed. They couldn't amplify or they couldn't determine susceptibility, so those were out. And then of those, 101 were not susceptible to both antibodies. So you're left with whatever that comes to, but around 100 participants. So a lot of people who might want this are not going to be eligible because of susceptibility. And that, of course, adds a layer of complexity to using these regimens. There are other issues as well. Logistics is one. Not every HIV clinic has a nurse who can do IV infusions. So some people would have to go to an infusion center. The cost is likely to be very high. And I think one of the most challenging things to think about is who is this going to be indicated in? The studies are all in people who are doing great on oral therapy, not people who can't take oral therapy. So when you try to go to a payer and say, this person's doing great on oral therapy, which in the not too distant future might be cheap and generic, and I want to switch them to this antibody, the payer might say, well, why? They're doing great on their oral therapy. So lots of challenges, but I don't think that's a reason not to pursue this kind of treatment, given the fact that every 6 months could be a game changer for some people.
It would be wonderful to be able to give somebody their injections or infusions every 6 months when they come in for a 6-monthly clinic visit.
Absolutely.
Switching from exciting intermittent or long-acting therapy to what most people are on, which is daily regimens, there was additional data on Dolutegravir 3TC from the Vogue trial, which was actually the first RCT of Dolutegravir 3TC among ART-naive participants. This trial compared Dolutegravir 3TC to BIC-F-TAF. One of the things that I found interesting about the study, or perhaps made it a little more powerful, is that they really sought to have minimal exclusion requirements. That is, they did not have restrictions regarding baseline viral load, CD4 count, or pre-treatment HIV drug resistance testing. About 500 participants were randomized with a median age of 33 years. 16% were women, 16% were non-white, 16% had a viral load greater than 500,000, and 16% had a CD4 count less than 200. At week 48, 89% in the Dolutegravir 3TC arm and 92% in the BIC-F-TAF arm had a viral load less than 50. Joel, your reflections?
This is an important study because for the first time, we're comparing what are basically the two standard of care regimens that are in use today in a large head-to-head phase 3 study in naive participants with, as you said, no viral load or CD4 restrictions. And there were plenty of people in the study with low CD4s or high viral loads. This trial showed non-inferiority with, importantly, no resistance. The data for Dolutegravir 3TC in clinical trials has been very strong, and this certainly strengthens the data. The caveats, of course, are again hepatitis B, and especially in a situation where you're doing rapid start and you don't yet have hepatitis B serologies back, BF-TAF clearly has the advantage there. The other thing to note about this is there was really no advantage of Dolutegravir 3TC, no disadvantage, no advantage. The weight gain was about the same. Both groups gained weight, as you'd expect in somebody starting a new regimen. It was about 4 kilograms in both, arguing against what some people thought of a TAF-associated weight gain. So this is a really important study. It gives us greater confidence in Dolutegravir 3TC. I still think there may be a somewhat lower resistance barrier, and that's not based on clinical trial data. It's based on observational studies where you had populations enriched for poorly adherent people who tended to do better on BF-TAF than Dolutegravir 3TC. So I think that, that's another issue with rapid start is you don't know anything about the adherence of the person you're about to start. But in an adherent patient without 184V, this gives me much greater confidence in Dolutegravir 3TC as an appropriate regimen along with BF-TAF.
So there have certainly been observational studies looking at Dolutegravir 3TC and then retrospectively looking at resistance. And some participants with undetectable viral loads have been found to have the M184V, and similarly in BIC-F-TAF studies. What is your level of concern about ruling out M184V or using either of those regimens in somebody who may have the 184V?
Yeah, it's a great question. Undoubtedly, people are using Dolutegravir 3TC in people who have that mutation and they don't know about it, and it mostly works. There have been some observational studies, mostly from Europe, where 184V was a risk factor for virologic failure. We haven't seen that kind of a problem in trials, but then trials tend to select for a different patient population. So I wouldn't purposefully use it in somebody who I knew had a 184V, but it gives me a little bit of reassurance that if I miss the 184V, it's probably going to work. There was a study presented here looking at a group of people who were not allowed to take dolutegravir 3-TC if they had a known historic 184V, but they did find that there were people with that mutation by proviral DNA, and they did well. But it's a fairly small number. And again, it comes with all the baggage of the proviral DNA genotype that some people have more confidence in than others. So just like with Islatravir, I wouldn't knowingly use it in somebody with 184V, but it's nice to know that it's probably going to work most of the time.
We shift now to the realm of NCDs and HIV, certainly a topic that's had a lot of attention overall in the world of HIV management. One of the big aspects has been weight gain, and there were several studies addressing weight gain. One was the Paso Doble study, which conducted DEXA and abdominal CT on participants randomized to either BIC-F-TAF or dolutegravir 3-TC. Total fat increased and lean mass declined with both regimens, and metabolic metrics were largely unchanged at week 96 between those two regimens. The other study was the Optidor trial that was conducted in South Africa among ART-naive individuals with a BMI of greater than 25, and that compared doravirine 3-TC and TDF to dolutegravir F and TAF. In that study, there was greater weight gain in the dolutegravir F-TAF arm compared to the doravirine 3-TC TDF arm, although virologic suppression was excellent in both arms. What are your takes on weight gain and learnings from both of these studies, how we manage our patients?
Yeah, we'll start with Paso Doble because I think that's the most relevant for HIV care in the United States, because dolutegravir 3-TC and BF-TAF are the two regimens we're most likely to be using. And this was a randomized trial of people who were previously on efavirenz, TDF, or cobicistat and taking more than one pill per day. They randomized them to switch to either dolutegravir 3-TC and BF-TAF. They did see more adiposity. It increased in both arms, but increased more with BF-TAF, and there were more people who had at least 5% weight gain. Subcutaneous adiposity stabilized over the first year, but visceral adiposity continued to increase without any difference in metabolic markers. There were plenty of other risk factors for weight gain: lower diet quality, being a woman, longer prior ART exposure, and lower baseline total fat by DEXA. These results are a little inconsistent with results from other studies, including the Vogue study, which was the head-to-head study we just talked about, where they didn't see any difference in weight increase. Switch studies are more complicated because, remember, efavirenz and TDF are both weight suppressive drugs. So anytime you switch off of efavirenz or TDF, including to TAF, but even if you just stop those drugs, you're going to see weight gain because you lose the suppressive effect of the efavirenz or TDF. It's not necessarily because TAF is causing a weight increase. Similar, if you switch from efavirenz to integrase inhibitor, you'll see this weight increase. People have said, oh, integrase inhibitors cause weight gain, but it may have more to do with the fact that they're not suppressing weight in the way that efavirenz does. We'll come back to that when we talk about Optidor. But again, a big randomized trial should be able to take care of that, although I don't remember seeing the details about what people were switching from. But whenever you analyze weight gain in a switch study, it's critical to look at not just what are they switching to, but what are they switching from. That being said, I would say the weight increase here the difference is statistically significant, but modest, and nothing in comparison with what we're now achieving with the GLP-1 agonists, where if you're really worried about weight gain, those are going to be far more effective than any change in antiretroviral therapy. And we know now that switching therapy has not been effective at dealing with weight gain that occurs on ART. Now let's talk about Optidor. This was in South Africa, and it's different because this is comparing doravirine 3-TC and TDF with dolutegravir FTC and TAF. This was a large study. About 2/3 were in women. Viral suppression was great. Importantly, 9 people in the doravirine group had virologic failure, 7 with doravirine and nucleoside resistance. The 6 who had virologic failure in the dolutegravir arm had no resistance, as we would expect. So clearly a lower barrier to resistance with the doravirine than integrase inhibitor, which is why I think integrase inhibitors should continue to be our go-to first-line regimen. They did see less weight gain with the doravirine regimen than with the dolutegravir regimen, and less visceral adipose tissue, but that, again, has to do with the weight suppressive effect of TDF. Although everybody likes the idea of weight suppression and taking a drug that might suppress weight, I would point out that in package inserts, weight suppression is listed as a toxicity of TDF. And when a drug causes weight loss or weight suppression, we should probably think of that as a toxicity until proven otherwise. So I don't think we should all have our patients rush out to go back to TDF just because it might make them weigh 2 kilograms less. I think the toxicity of TDF has been pretty well established. This study just confirms that an integrase inhibitor based regimen is the way to go, both in the US and in other parts of the world.
And lifestyle management or GLP-1s are the approaches, I guess, to trying to help our patients managing goal weights.
Absolutely. And we already know from multiple studies that once somebody's gained weight on antiretroviral therapy, switching therapy is not going to make a difference. The only exception to that rule might be if you were to go back to TDF or efavirenz because of their weight suppression, but we're not supposed to be going backwards. We're supposed to be going forward. So we shouldn't be going back to drugs that we've given up in the past because of problems with those drugs.
Shift to HIV prevention. Prior conferences really had a lot on PrEP. This had less, perhaps because the world of PrEP is maturing. There was a provocative session on PEP or post exposure prophylaxis, in which there was a discussion of bringing long acting agents to PEP, even potential one time dose for PEP, which would certainly increase adherence to PEP, which usually is around 50 or so percent if it's a 4-week PEP regimen. I thought that session was interesting. There were presentations on Lenacapavir with the open label extension data from Purpose 1 and Purpose 2, as well as on Cabotegravir for PrEP implementation, both on CAB in pregnancy and also a study from Brazil on false positive rapid HIV tests among people on Cabotegravir. How do these findings help guide your approach to PrEP?
That PEP study, I didn't see it, but I think you're referring to the Merck oral drug that can be dosed once a month. Obviously, that would be great for PEP because we usually use a 1-month regimen and you could just take a single dose. That's also going to be studied for long-acting oral PrEP. Although it's once a month instead of once every 6 to 12 months, the fact that it's oral could be a real advantage. The drug already has a generic name that I can't remember at the moment. We saw more data from the Purpose 1 and Purpose 2 trials, which are for lenacapavir given every 6 months. The Purpose 1 is in cis women, Purpose 2 is in men and gender diverse individuals. And these two studies now look at the open label extension phases of the two studies where they continue to see truly incredible results with very, very low rates of acquisition. For example, in Purpose 2, there had been 3 previously described acquisitions, and there was one new one in this open label extension phase. People got used to hearing about the 100% efficacy in Purpose 1. And then they say, well, what's wrong with it if there have been 4 infections? But when you're talking about the very large number of people in these studies, we're talking about like 0.11 per 100 person year incidence, incredibly effective. So these are very exciting. And of course, Gilead is doing work on an intramuscular every 12-month injection of lenacapavir as well. We saw an interesting study from the US looking at a national claims database about use of injectable PrEP from June to December of 2025. They found that lenacapavir accounts for about 1% of all PrEP use, and cabotegravir accounts for about 5% of all PrEP use, probably way lower than it should be given what's going to work for people. And they also found that with lenacapavir, PrEP equity was lowest for Black individuals, Hispanic, young people. Interestingly, there was more lenacapavir use with Medicaid than with private payers. So we've got some work to do to get this out there. There was some good data on CAB use for PrEP in women, including pregnant women. The OPERA cohort looked at over 5,000 people, of whom over 300 were on CAB for PrEP. They found no acquisitions. These are cis or trans women, and that was with about 88% of people getting on-time injections, and they didn't see any safety concerns. And then the PRIMO study in Malawi looked at 400 women who got CAB, 200 got oral PrEP. This was not a randomized study. But they did find that the outcomes with CAB for PrEP were similar to those with oral PrEP, giving us reassuring data for women and including pregnant women. And then there was an interesting study from Brazil where the conference was being held, an implementation study of Cabotegravir called, I think it's pronounced IM PrEP. One of the concerns about CAB for PrEP is this problem where people can become infected or at least test positive despite on-time injections, which we don't tend to see with oral PrEP. So in this study, 14 individuals or 1% had a positive rapid test. Then they followed with, as they should, with a commercial RNA assay, and that was negative. So then you're left with this conundrum. Is the positive rapid test a false positive, or is the RNA assay a false negative? They then did ultrasensitive RNA assays, including single copy assays and cell-associated DNA assays on these individuals, and all were negative. So they concluded that when you have a positive rapid serology and then a negative commercially available viral load assay, these are probably false positive tests, which is very reassuring.
Yeah, definitely. I echo your call for increased delivery of lenacapavir and cabotegravir for PrEP. And certainly, as you pointed out, a couple of seroconversions on lenacapavir, while each one is unfortunate, doesn't take away from how amazing this product is and how important it is to reach better equity both in the US and globally with lenacapavir. And hopefully in future conferences, we'll hear more about that.
Yeah, absolutely. I think long acting PrEP, and I would include long acting oral PrEP as well as injectable PrEP, is a revolution. I remember Chris Byrer, formerly at Hopkins, now at Duke, at one of the recent conferences said, this is a revolution that may never happen. That would be really sad if true, because I think using the appropriate form of PrEP in people who are in need of PrEP could end this epidemic. We need to put all of our resources and energies into making that happen.
I wanted to end on PEP for STIs or post exposure prophylaxis for sexually transmitted infections, or doxy-PEP, doxycycline 200 milligrams within 72 hours of potential sexual exposure to an STI. There were several doxy-PEP studies presented at the conference, one of which compared STI diagnoses pre and post prescription of doxy-PEP among 219 people receiving care in a health system in the US. There was a median age of 37, 97% were men who have sex with men, and 52% were living with HIV. Before receiving doxy-PEP, this group of patients had 8.2% STI case positivity compared to 3.9 after receiving doxy-PEP. This wasn't all behavioral change or as a result of having the doxy-PEP in their pocket. Looking at the different STIs for gonorrhea, there was a modest decline from 10.5 to 7.5%, bacteria with fairly high levels of doxycycline resistance. While for chlamydia, the decline was from 9.5 to 2.3%, and for syphilis, 4.5 to 1.8%. Findings that are fairly consistent with some of the clinical trials of doxy-PEP. This and other doxy-PEP studies validated some clinical practice and hopefully will encourage others to prescribe doxy-PEP more widely. Any thoughts, and how do you approach doxy-PEP?
The Duke study from North Carolina was the one I'm most familiar with. I thought it was this pre and post design that looked at what was going on before doxy-PEP and what's going on after. And they saw a 2/3 reduction overall in STIs, which is quite remarkable. The biggest decrease, as we've seen in every study, is syphilis and chlamydia. The decreases in gonorrhea incidence tend to be smaller, and that's not surprising because we certainly don't think of doxycycline as a great treatment for gonorrhea. But for syphilis and chlamydia, it's very striking. So that alone, I think, is a reason to be using this more broadly. But of course, it doesn't take away the need for regular testing, especially because, again, you're not going to see as much of a decrease in gonorrhea rates. People worry about the effect on drug resistance. I don't think we're going to see that with syphilis and chlamydia. And if we see gonorrhea resistance, oh well, it's not like we rely on doxycycline for gonorrhea. Maybe the bigger concern is the effects on microbiome, effects on Staph aureus. But I think the benefits of doxy-PEP in these many studies are overwhelming. And these theoretical concerns should not be a reason not to be using this widely.
So, Joel, this has been fun. I always learn from your insights and appreciate that you continue to mentor me in HIV care. Any other reflections or thoughts from the Rio conference?
Yeah, I think it was important that this meeting was held in Brazil. Some people said, well, it's a difficult place for a conference, but it was important for it to be there because Latin America is a place where the incidence of HIV is increasing at a time when it should be decreasing. And Latin American sites have also been important research sites where, a lot of these PrEP studies have been done, for example, and yet we're not seeing widespread availability of the very things that they were studying in those areas. So it brought attention to that. And so I was glad it was there. In terms of HIV care practice, what do we need to think about? Well, obviously, we need to think a lot about who's going to be getting long-term therapy, who's going to be getting these regimens that don't have to be given as often. And some people say, well, won't that be everybody? No, obviously not. Certainly in my practice, there were plenty of people who were older, taking lots of pills for their hyperlipidemia and hypertension and depression and things like that. And one additional pill was meaningless to them. But I think there is a subset of people for whom long-acting therapy is going to be incredibly useful and could mean the difference between virologic suppression and non-suppression. But I also think that just a word of caution for providers, with this growing interest in two-drug regimens and long-acting regimens, virtually none of them contain tenofovir. So we have to really, really be cognizant of hepatitis B status, of not forgetting about the people who are chronically infected, and about making sure that people who are on these regimens are immune. Fortunately, that's a lot easier to do now that we have the better hepatitis B vaccine that's far more immunogenic. Vaccines in general, I think, can't be underestimated. There was a study from the Max and Wise cohort showing huge increases of HPV-related cancers in people with HIV, anal cancer, genital cancer, oropharyngeal cancer, ranging from 3 to 7-fold higher than in the HIV negative population. But what was sad was that in these populations, less than 5% had been vaccinated against HPV. So we got to remember when we're HIV providers to put on our primary care hat and keep those things in mind as well. So that's some of my take homes.
Joel, a huge thanks again for providing these insights and discussing AIDS 2026.
It's been a real pleasure, Chris. Thanks so much for inviting me.
To our listeners, thanks for joining in to another episode of Viremic. Please send any comments or questions to viremicpodcast@jh.edu. And we'll be back in 2 weeks with management considerations of perimenopause care for a woman living with HIV.
Viremic is sponsored by the Clinical Guidelines Program, a collaborative effort of the New York State Department of Health AIDS Institute and the Johns Hopkins University Division of Infectious Diseases. Visit the program's website at hivguidelines.org. Viremic's case discussions are for informational purposes only and not offered as medical or clinical practice advice for patients or clinicians. Any mention of specific medications or commercially available products is a description of use only, not an endorsement. The podcast is produced and edited by Mary Beth Hansen and Brian Hatcher, with assistance from Jesse Seacott and Laura LeBrun Hatcher.